discussions around palliative care and hospice and what people's wishes were. The religious right came out in droves, and the former vice presidential candidate Sarah Palin dubbed this death panels, that we're going to kill grandma. We're going to have doctors making decisions about end-of-life care when people's lives are not worth anything. My organization, Compassion and Choices, fought like hell in Washington to get Medicare and Medicaid to pay for those discussions that doctors would have about improving end-of-life care. And you know what? Just a few months ago, we got it. And now that kind of care is reimbursed. The second point I'll make is that the Hemlock Society still exists. It's a separate and distinct organization from my own. We didn't go through a rebranding. We have a different organization. And our organization is centered around principles of autonomy and about improving end-of-life care. So I just wanted to make that clarification.
Okay, thank you. Next speaker, Jerry Morrissey. Question, Jerry?
Good evening. I do have a question. And I'm going to pose this question to any of the panel members that would like to respond. My name is Jerry Morrissey. I've been a hospice worker for 25 years, so you'll know where I'm coming from on this. I'm opposed to this proposed legislation, and I'll tell you why. I'm not going to go over all the pros and cons that have already been discussed. I'm going to raise one concern that I don't think has come up and ask you to comment on it. And my concern is that the proposed legislation makes physician-assisted suicide much more a mainstream option. That New York State's endorsement, as some would say it, certainly an acceptance of this option, puts pressure on the patient. And my comment is that my question to you is, do you agree that there is an issue of pressure when the state endorses a system which now presents what some people will take as a mainstream option? When you take a patient who's gravely ill and very aware of the strains on their family, and I've seen those for 25 years, suicide option may come to be viewed as the expected course. New York State sets out an option which would never have been permitted before. And for some patients, a suicide course would never have been considered, but now becomes socially acceptable and endorsed by the state. In fact, some experts in the field say it's come to be viewed by some patients as, quote, a duty to die in order to spare their families. I believe that's a real pressure that the state is considering imposing on dying patients. I ask you to consider this as a potential new pressure which the New York State can accept or reject, and I'd like your comments on the notion that I've described of pressure being opposed by the state to accept something that they never would have considered an option before.
I can go.
Sure, I can go first.
All right, I'll start this one off if you want, and then you can correct me, please.
No, go ahead.
So look, I don't think there's going to be any direct state pressure, but what I do think happens is whenever a new ethical line is drawn, at first there's going to be controversy, and then it's going to become obvious. You see that, I mean, with regards to the distinction between withdrawing and withholding that they used to have, and between medication and nutrition, that there used to be a distinction. Now, if you ask a medical student, you know, should there be a distinction, there's like no moral questioning whatsoever. It's obvious that, you know, withdrawing and withholding is the same, and everything's considered medical nutrition without any thinking about, you know, why it's come to that. So once something gets part of the social and the medical and the healthcare conversation, there's always going to be indirect influence in terms of, oh, well, there's a reason why that option is there. That's an option that now is available. And now it's one I should consider, right? So that's how I would say that the influence comes. It's more indirect and social than it is, you know, a coercive act by the state.
I'm not suggesting it's coercive, but I'm asking if you would believe that a New York State endorsement of assisted suicide would not create a pressure that did not exist before on a patient?
No, I think the pressures, look, being allowed to and having to are different things, right? But being allowed to and considering it heavily is not because of, it's now permitted. It's because everyone else is doing it. I mean, that sounds flippant, but you know what I'm saying. Once something becomes more popular, then it becomes more of a consideration. I think that, once again, legislation would now bring it into common discourse. It wouldn't, in terms of it being now permitted, it wouldn't say, oh, well, if the state says it, I have to do it. I don't think people will think.
No, I don't think
anybody's
anybody's suggesting that the state is forcing anyone to do it.
Okay, so then I don't. Then what? I don't understand the question.
No, my question is whether it creates an incipient pressure on somebody to act on what they sense is the problem that their family is dealing with.
I can try to answer that question.
Go for it.
So I think someone on this panel raised before that in 1994, the New York Task Force on Life and the Law issued a report recommending that New York not adopt physician-assisted suicide. And so you're raising some of the same concerns that that task force, which was made up of a number of different professionals, raised. 21 years since that report, though, we've learned an awful lot. And in Oregon, we have 17 years of experience with this law. And I think some people, when the Oregon law was adopted, thought that there would be a rash of suicides, that it would increase, that the number of people, would take advantage of this option. In fact, it's only a small percentage of people in Oregon who've taken advantage of the law, and there's been no huge uptick in the number of people as that's become more accepted in Oregon. So I'll just tell you that we were talking a little bit about data available from Oregon. There are 2 reports in the back. Oregon's law has been under a microscope for the past 17 years, and there's a lot of data available. It's been studied by a number of entities. There's a meta-study on the back table, and there's also a year 17 study that talks about the demographics and about the circumstances surrounding. And so I understand the fear that you're raising, and it has been raised in the past, but we just haven't seen it play out that way in Oregon, and I don't expect it to play out that way in New York State.
We do see, however, just so that your point is well taken. We do see, however, that social acceptance does have an impact. So one of the things that people find uncomfortable to talk about is parents who kill their disabled children. So, which is something that happens. I can give you examples, basically where the father has taken the daughter with cerebral palsy, put her in the garage, turned on the car, and then closed the door, and then put her back to bed. That type of thing has actually had basically echo responses. When the family members get the support for you did what you needed to do, it does create sort of a push in that direction. And I don't think that the issue is necessarily, in some cases there are concerns about coercion, but I think you're getting to the issue that I was trying to raise. It may be very subtle. When you are feeling dependent on someone, you are watching for cues of that person, and it may just be that your daughter is particularly tired that day because she had a fight with her boss, but you may interpret that as you feeling that you're a burden to her, and that may make you feel pressured to move in this direction.
Yes.
Okay, thank you, Jerry. Okay, our next questioner.
Alan Meldor, South Salem. You had mentioned about the New York State Task Force on Life and Law. In '94, they did come out, and then it was restudied again in '97, and they again came out saying, we unanimously recommended that New York State retain its prohibition of assisted suicide and euthanasia. And then it goes, after extensive study, we've concluded that legalizing these practices would be profoundly dangerous for large segments of the population. Now, you mentioned your main opponent in this whole effort to pass the law is the Catholic Church. There's someone called the American Medical Association who says, however, allowing physicians to participate in assisted suicide would cause more harm than good. Physician-assisted suicide is fundamentally incompatible with physicians' role as a healer. would be difficult to or impossible to control and would pose serious societal risks. And then they mentioned there's some 36 different medical organizations
could you
here
just ask
that
the
have
question?
taken it. I'm coming to the question. So when you say it's difficult or impossible to control, do you feel that once you pass this law, that in fact these limits might change, or they may not be held to strictly, such as in Oregon in the 10th year, nobody was referred for to psychiatric examination on depression. And what's happened in Europe when we find that assisted suicide has become euthanasia? How do we control this as a creeping event that will come down the line? That's my question.
So there were a lot of questions in there.
Well, it was just
I'm gonna-
basically, how do we control
Sure.
this thing? Because we've seen it in other places where it doesn't happen.
Sure.
Oregon, there was nobody
Yep,
counseled. And we know they had to be depressed.
Well, you're citing 1 year of data. In fact, last year there were folks that were referred for
A large
counseling.
percentage?
But what folks who were determined to not have the capacity to make the decision because it was impaired by depression or other psychological conditions. But let me go back to the other thing that you said. Well, a couple of things that you said. The way that you control changes in any law is having a public dialogue about it. The Oregon law has remained unchanged. And there have been none of the cases of abuse that the Task Force on the Life and the Law thought would happen. Profoundly dangerous are the words that they used in their report. But in fact, all of the things that they predicted might happen from the Oregon law did not come to pass. And the Oregon law has remained unchanged. If there were a move to change that law, Oregon would have the same kind of dialogue that we're having here, and I would encourage that because I think it's important that everyone understand what it means. As for the American Medical Association opposing this, the American Medical Association was one of the last organizations to come around when it came to allowing folks the ability to withdraw life-sustaining treatment as well. Sometimes it takes a while for institutions to change, and sometimes it takes individual medical doctors to change their institutions. And I think that that's what we'll see here in New York and across the country, is that individual doctors will change the AMA.
You said the law hasn't changed in Oregon. My question wasn't really, has the law changed? Has the adherence to that law changed? And that's what we see, and I have a book full of different instances, so that's the question. I'm afraid that you can make a law, and then the doctors might not go along with exactly, and the fact that nobody was had psychiatric treatment or examination that year, somebody had to be depressed. Okay.
I think this comment and the comment before share something in common, which is that both are concerned about a slippery slope, how things might go wrong if this is legalized. And I'd like to point out that no matter that if we do pass this in New York, that we not make the mistake that the Vermont legislature's made. And I'd like to have this be something that's really could come out of this hearing. In most of the other states where there's, and I think in all the other states where it's legalized, there is continued monitoring, because that would speak to this question, especially the last person's comment. There's continued collection of data that's mandated along with the law so that we can study it. But in Vermont, they sunsetted the monitoring. So the Vermont legislature legalized aid in dying, but they expressly said that after some number of years, and not that many, I think it's 3 or 4 years, that the state was to no longer collect data. And I think this was done for really confused, on the basis of very confused reasoning. The state legislators argued that continued data monitoring would be an intrusion on the privacy of the doctor-patient relationship, and that the state should not be in the business of collecting the data. And I think that's a tragic mistake, because there are legitimate slippery slope concerns, as these last 2 commentators have just made. We can still legalize it for a variety of reasons, but to say that we're going to legalize it and not monitor it is, in my view, really short-sighted. And I hope that New York, if it does legalize, will not follow suit with Vermont.
I just want to, the question was, I think that's a fair question about folks who are depressed. The thing is, depression is not just something, I mean, we all as lay people think, oh, my best friend's depressed. It seems like it's something pretty straightforward. You know it when you see it. But it's not actually that easy to diagnose. My husband happens to be a counselor. And what they found actually in Oregon is only 6% of Oregon psychiatrists are confident that they can diagnose depression in one visit. So, but that is what is given as the consultation. So depression actually is a much longer term issue, and it is something that needs to be, you need to actually build a rapport with the patient. So one of the concerns that I have is that there is a potential problem here related to people who are depressed, that there are issues in Oregon that are not being surfaced, in part because we may not actually have the infrastructure there in Oregon to identify those issues.
Good evening, everybody. My name is Mel Tansman. I live up here in Mohegan Lake, but I'm also the executive director of Westchester Disabled on the Move, which, like the Center for Disability Rights, is an independent living center for people with disabilities. I promise that I will have a question that will be directed towards Ms. Carey. However, I do think I want to make a few points that are based on my own personal experiences, one very, very personal, and one having to do with professional. And the question in the end is going to be the appropriateness of physicians to be the gatekeepers, and the issue of ableism, and the issue of the slippery slope, which I think this Dr. Solomon pointed out. It is a valid concern. Real quick, when we adopted my daughter when she was 3 years old, several months after she was adopted, she developed juvenile rheumatoid arthritis in a very terrible condition of it. High temperatures, a long stay in the hospital, and when we took her to see a physician, a very well-known physician, a rheumatologist, his question to us was, why don't you just send her back? P.S. She's now 20 years old, and the rheumatoid arthritis is totally no sign of it. The other thing, and this was a more professional-based experience I had in the last year, one of the things our center does is help people get out of nursing homes. Young man at 27 years old had a motorcycle accident causing a brain injury and also the amputation of his right arm and right leg. He was told when he went to a rehab facility that rehab was useless, that because of the TBI, the signals from the brain were no longer going to the other parts of the body. He could have done two things. He could have accepted that, become extremely depressed, and probably want assistance with ending his life. Or he could have gone and tried to get a second opinion. Luckily, he tried to get a second opinion, and the neurologist said to him, no, all the signals to all the parts of the body are still going there. All those systems are working. So thankfully, he had to force the nursing home to give him the rehab that was appropriate. So I guess my point is, and my question is, what makes physicians who have, some of whom have very ableist attitudes, the most appropriate gatekeeper? And let's not also forget that, AIDS used to be a death sentence, and that wasn't too long ago. So that's my question.
So your question is, what makes physicians an appropriate
why are they appropriate when some of their attitudes may be, ableist or prejudiced in many ways?
I think my answer is simple. They're not at all. Physicians are not the gatekeepers here. Individual people are the gatekeepers. They're the ones that make the request for the medication. They're the ones that have to express the desire to take it. And as I said before, in the Oregon experience, folks who get the medication then make many other decisions afterwards. Sometimes, 2/3 of the time, they end up taking the medication and ending their lives, but it is ultimately an individual. I think you also were asking, about whether this is an appropriate role. I think the examples that you gave, those are completely inappropriate behaviors for physicians. And I don't think you'd find a person in this room that disagreed with you. Those are horrible responses to terrible situations. And I'm glad that both of these individuals pulled through in the end, and thank you for raising them. One of the arguments that we hear is that it's a physician's first duty to do no harm. And I think what I would ask folks to consider is, what does that mean when someone is suffering and is going to die? Is it harmful to refuse to help that person? The suggestion that suicide is an option without this law, that someone can take a gun or use some other violent means to end their lives, is just, I find it insensitive. I'll leave it at that.
And this is Bruce. I just want to, the point I was trying to make was not that you should take a gun and violently end your life and make your family's life a living hell in the aftermath. That is not at all what I was suggesting. Voluntarily refusing to eat or drink and receiving palliative sedation and palliative care at the end of your life is an option that currently exists. It is an option that reaches the same goal. It may not be immediate, but it also assures that individuals are not coerced in the process. So there are clear examples where, like Kate Cheney, who was 85 in Oregon, she was actually, when her physician wouldn't prescribe her the lethal dose, the managed care organization made a referral to one who would. And when she got her second evaluation and there was a question raised, the daughter became angry. And it was clear, ultimately, that the daughter may have had a coercive influence on this individual. It was noted in the record, but she was still given the medication. Because it's self-administered, no one knows whether she took whether she took the medication herself. But what we do know is she took it after she was placed in a nursing facility for a week. So there are clear issues of coercion, the things that people fear. There are minor things that people may do that are not intended to be coercion, but may signal to someone who's feeling a burden and dependent. So I just want to acknowledge that. And then we had mentioned that people needed a terminal illness. I just wanted to acknowledge there are some intersections on this. ALS, let's just take that as an example. ALS, Lou Gehrig's disease. A lot of people may think of that as a terminal illness, but it actually is a disability as well. And where the prognosis is unclear, that is a person who could otherwise may have lived a life that was cut short. And frankly, just so that you're clear, okay, 16% of the folks in year 17 in Oregon had ALS.
So this is looking forward a little bit, but in countries that have legalized physician-assisted suicide, the debate has often turned to questions of access to this right by people who live with persistent, chronic, and incurable mental illness. And in some countries, people living with mental illness have chosen to die with dignity via physician-assisted suicide, usually with additional safeguards in place and after having exhausted all other treatment options. But tonight, as is often the case, we speak of screening out those who live with mental illness, we dehumanize them using legalistic competency language, and we suggest that these people abdicate their right to decide how they live and how they die. Why are we treating these people as incapable of choosing dignity in their deaths? And ethically, how can we make this distinction without simply relying on the 6-month terminal diagnosis or prognosis stipulation? Thanks.
All right. I want to thank you for that question. I think it's a brave one. And I think that from my perspective, from our perspective at Compassion and Choices, the legislation that we're looking to pass in New York is about autonomy, but it's also about ensuring that folks that at the end of their life have an option to choose the way that they die. These are the issues that you're raising are different, and I will say that they they deserve fuller debate, but that's not the End-of-Life Options Act that we're talking about here. But I'll allow my fellow panelists to address it.
Anybody want to comment, or we'll go to the next?
There's been actually a very interesting conversation between individuals in the psych survivor ex-patient consumer community and individuals involved in Not Dead Yet, where they've actually found a lot of common ground around concerns related to loss of autonomy, where physicians actually weigh in and take control, and the concerns about coercion. So there is, for, I don't know if she's still here, I lost her.
She's back here.
There is you want to connect afterward, I can maybe engage you in that conversation and connect you with folks, because there is a real significant conversation within the disability community.
Interesting. I just want to share something with you that I think you will also find quite interesting. Quotes, whatever its motives and means, direct euthanasia consists in putting an end to the lives of handicapped, sick, or dying persons. It is morally unacceptable. Thus, an act of omission, which of itself or by intention causes death in order to eliminate suffering, constitutes a murder, gravely contrary to the dignity of the human person and to the respect due to the living God, his creator. The era of judgment into which one can fall in good faith, and I'm going to just say here, I think everybody in this room is here in good faith, but we do make mistakes. The era of judgment into which one can fall in good faith does not change the nature of this murderous act, which must always be forbidden and excluded. I wish I could claim credit for that, but that is paragraph 2277 from the Catholic Catechism, as everybody else in the culture. So I think the failures of members of the Catholic Church don't justify behaviors. They're sad, they're failures. My question, though, it has haunted me, even dealing with the issues of life with the preborn child. How do physicians who take the Hippocratic Oath and promise to do no harm, and you almost stole my thunder down there, Ms. Carey, but I'm asking the question anyway, how do physicians justify the idea of assisting someone in taking their life when they promise to do no harm? We are all going to die.
So I'm not going to address your first point, which is about Catholics and our views on this. I will say, I will go back to my earlier statement about religious liberty and religious freedom and say that 39% of New Yorkers are Catholic, and we don't have the right to impose our religious views on the rest of New York. And I think that's sufficient. But you cited the Hippocratic Oath, and I'm glad you did, because it gives me the opportunity to get to something that my time limit did not. And that is, less than a handful of modern medical schools have graduating medical students take that oath. If they administer any oath at all, it's either a modified version or it's some other professional oath. But let's stay with the Hippocratic Oath for a moment. You know, everyone knows that it's do no harm, but if you look at the time during which Hippocrates penned this oath, this was a time of tremendous upheaval in Athens. People were being poisoned left and right, and in political intrigues, and doctors were conscripted to poison others. Since the part about poisoning follows directly from a sentence that reads in translation, "From injustice I will keep them," it's probably more about vowing to refuse to take direction to poison others than anything else. And so I would just challenge us to look beyond some of those words and think about what translation means. What I said before is that what is doing no harm when someone is suffering? Is it doing harm to refuse to help?
And then I would just ask, I hear the issue, though, is, are you doing no harm to the individual patient, but what about the other people who are collateral damage to the policy? So we are not in the individual medical exam room or the hospital room or the individual patient's living room. We are looking at changing public law that would provide immunity to